Welcome to Module 4. This is the Haynes Method of Neuromuscular Dry Needling, the Haynes Method Hybrid Dry Needling Certification Series. This is Module 4, which is let me get down to it, covers the forearm and the leg. So a good bit of content that we're going to cover here. Here's a breakdown of what this module is going to contain. I'm not going to read all of this because we're going to cover it all in depth over the next 2 hours. We will have a post-module assignment at the end again for those who are taking this for ultimate participation in the labs and for the dry needling certification. So let's just jump right in. Let's start with some supporting evidence here from Uger from 2021. The use of dry needling versus corticosteroid injection to treat lateral epicondylitis. The background here, lateral epicondylitis or tennis elbow. They use different treatments to address this, being corticosteroid injections and dry needling. The question of which one is better has not been entirely discussed, and so they hypothesized that dry needling would be at least as effective as using corticosteroid injections. After going through their methods, the results indicated that 7 patients were excluded for various reasons. Thus, there were 101 patients finally evaluated. Before treatment, the groups were similar in terms of age, symptom duration, and the PRT-EE score. But after treatment, the dry needling treated patients showed better improvement in that score than the steroid injection patients. Both treatments were effective, however. From assessments at 3 weeks and at 6 months post-treatment, those scores did decrease over time. 4 steroid injection patients developed skin atrophy and whitening, and 1 dry needling patient could not tolerate the pain of intervention and withdrew from treatment. So the conclusion, dry needling and steroid injection afforded significant improvements during the 6 month of follow-up. However, compared with steroid injection, dry needling was more effective. And that's for tennis elbow. Here, one from Ceballos Laita. This was the effect of dry needling in hip muscles in patients with hip osteoarthritis, a randomized controlled trial. Their results, there was decreased pain intensity and increased hip range of motion, improved physical function following the dry needling treatment. Those improvements were statistically significant compared to the sham group. And the sham group had increased pain intensity and increased hip range of motion. The conclusion being that pain, hip range of motion, and physical function improved after the application of dry needling in active motor trigger points of the hip muscles in patients with hip OA. We will get into very specific dry needling protocols for hip osteoarthritis later in the advanced lecture for the hip. So a couple of studies there supporting the use of dry needling in being as effective as steroid injection for treatment. So really good treatment approaches for us there. So for our contents, we'll look at our live virtual module here, the introduction to forearm, the upper and the lower leg, and then our tendons and ligaments. So we'll look at our clinical decision making, how to identify which muscles are demonstrating neuromuscular dysfunction. We'll determine orientation of the muscle fibers. We're going to palpate across the muscle fibers to find the ropey muscles, and then we'll palpate along the muscle fiber to locate those focal points of dysfunction. So a little on clinical decision making. What we want to talk about is how to identify which muscles are involved, which are experiencing any sort of neuromuscular dysfunction. Those are the tissues that we want to end up dry needling. And so as we get later, as you get more experience going through the treatment protocols, you will find that you go target these specific areas first. But for now, I just want you to focus on the exact finger breadths that we're identifying in the labs. So one thing we want to do, we know that patient comes in complaining of pain in the lateral arm, tennis elbow type symptoms. So obviously one thing we want to do is find out, what is the exact muscle. That'll tell us where we want to needle. And so one thing we want to do first is be aware of the orientation of the muscle fibers. Here in the wrist extensors, fairly straightforward. Obviously the muscle fibers are going to run from proximal to distal. Other muscles, say in the deltoid, important to understand how that muscle comes across from its point of origin over to its attachment. So first thing we want to do, identify that direction of the muscle fiber. Second thing we want to do is in each muscle, so we'll go through our manual test to find out, especially this group, which muscle we're dealing with. So again, second thing we want to do is we want to palpate across that muscle fiber. Here we're looking for which structures, which muscles have that ropey sensation in there. You do that, you should feel almost a rope or a pencil laying underneath that tissue. And so that'll help you identify which muscle you want to target. Thirdly, what you want to do is then palpate down the length of that muscle fiber. And very frequently in that, you'll find the focal point of pain. And so it's just a process to help you go through and actually find out where the real problem is. In our case, even if we've got the focal point here, and we identify, okay, that's extensor carpi or extensor digitorum, we still then want to go through our procedure to identify and needle that in that place. Later, as you get more proficient, then you may find that you vary a little bit from that to actually go down to that point of tenderness. So again, just an easy way to identify which muscle we're dealing with by first identifying the orientation of the muscle fibers themselves. Secondly, strumming across, if you will, that muscle to identify if it seems to have some tightness going on. And then thirdly, to palpate down to identify any specific focal points of tenderness. Okay, so on to goodness, you can see there's a lot of muscles here we're going to go through. Fortunately for us, in this introductory piece with the forearm, we're going to treat the forearm flexor as a group and then the forearm extensor as a group. As we get into our advanced forearm modules, then we will target each specific individual muscle. So that's how we're going to treat our forearm, upper leg, lower leg, deep posterior lower leg. We'll target most of those muscles individually today, and then we'll talk about some of the more common tendons and ligaments. And in the forearm, we're going to look at, again, we're going to treat this as a single group. And so we're going to cover our anatomy here in just a second. But we've got here our common flexor tendon and the tenoosseous junction, the Pronator Teres, Polymerase Longus, Flexor Carpi, Radialis, and Ulnaris, Flexor digitorum superficialis and profundus, the Flexor pollicis longus, and then Pronator quadratus. And so we're going to cover each of these muscles. I'm going to leave this information similar to previous modules in the slides. They will be available on the student portal that you can download. But I'm going to move, for sake of time, I'm going to move down to our discussion of three-dimensional anatomy, and then we'll look at some live functional anatomy. So our 3D anatomy, let me jump up here. Okay, so the 3D anatomy here, the common wrist flexor group at the elbow. This is going to be the structures on the medial aspect. Let's start with the more superficial muscle group. As I move this around, this is going to be all of the structures that we see along that medial ridge that goes from almost midline of the cubital fossa that we can palpate and test for, going all the way laterally down to the olecranon. So first one, get that back over here. Pronator Teres. So it's, and let me pull that information up. So as you see, its origin, the medial supracondylar ridge of the humerus, and also via the common flexor tendon, and also on the medial aspect of the coronoid process of the ulna. So it's got a diverse, let me fade those others. So both origin off of the ulna and the humerus in this bifurcated muscle itself. We look back at it. Let me bring those others back in. It's insertion, the middle 1/3 of the anterolateral aspect of the radius. So here we are in the anatomical position. The proximal 1/3, it says the middle 1/3. I would call it closer to the proximal. Anyway, its action is it pronates the forearm at the radial ulnar joints. The next muscle in line, so that muscle gets really important whenever we get to the dry needling. We're going to needle that medial and the lateral group based on some anatomical structures that we have. On the medial aspect, being able to identify Pronator Teres is definitely our landmark for needling, say, golfer's elbow through this bulk of muscle. So we'll move on to, let me reduce that. The next one in the row is going to be Flexor Carpi radialis. Highlight that. And so as you can tell, it's got again, a proximal origin. There on the medial epicondyle of the humerus, again, via the common flexor tendon. So this one now we're going to be seeing all of the remainder of these muscles. It shows them being very distinct, but it's generally referred to as being a single common tendinous structure across all of those. It inserts the palmar aspects of the bases of the second and third metacarpal bones, so very far distally. You see that in yellow there. So Flexor Carpi radialis crosses the carpal rows themselves. And then its action is it flexes the hand at the radiocarpal or the wrist joint, and it abducts the hand at the radiocarpal and midcarpal joints. Its innervation is the median nerve. We move from there. Let's see if there we go. The next in the row is going to be the Polymerase Longus. So Pronator Teres, Flexor Carpi radialis, and then Polymerase Longus. For that muscle, again, that would be, as you see down at the wrist, if you resist wrist flexion, that's going to be that tendon that pops up right in the carpal row. Its origin, the medial epicondyle at the humerus, again via the common flexor tendon, and inserts into the palmar aponeurosis and the flexor retinaculum of the hand. And so again, that's what we're going to see pulling up your resist wrist flexion. It's going to put some tension on that palmar aponeurosis. Innervation in median nerves 7 and 8. We move lastly to the Flexor Carpi Ulnaris. Get that highlighted. Perfect. Here, the origin again, the medial epicondyle of the humerus via the common flexor tendon, and then the proximal 2/3 of the body of the ulna and the olecranon of the ulna. So this, whenever we do start to talk about our specific protocols when treating for ulnar nerve entrapment, we can actually come in. This Flexor Carpi Ulnaris, very important for treatment of ulnar nerve entrapment, and we can really do a good job of needling there, and get a little bit more specific down into the ulnar collateral ligament, and there's another that we'll talk about when we get to that. But those are the 4 more superficial medial muscles that we deal with when we're needling there. So let's also now go take a look at the deep musculature. I'm going to switch Where did I go? Here I went. So for the deep musculature, here we're going to look at flexor digitorum superficialis, profundus, and then flexor pollicis longus, and then the pronator quadratus. Flexor digitorum superficialis, close that there. All right, I've got it hidden or faded at the moment, but let's pull that up. Its origin, the medial epicondyle of the humerus, again via the common flexor tendon, and the sublime tubercle of the ulna, and the proximal half of the anterior border of the radius. So really large footprint as far as its origin. It inserts into the palmar aspects of the bodies, the middle phalanges of the index, middle, ring, and the little fingers. And again, actions here as it flexes those same digits 2 through 5. Innervation is C7 through T1 via the median nerve. We go a little bit deeper and look at flexor digitorum profundus. Bring that back around and zoom back in. And so profundus sits deep to the superficialis. Origin, the medial aspect, the coronoid process of the ulna, the superior 3/4 of the anterior medial surface of the body of the ulna. It inserts into the palmar aspects of the bases of the distal phalanges of the index, middle ring, and little fingers, and their action is flexing, again, digits 2 through 5. Here again, innervation. The medial part, curious thing, medial part is of the ulnar nerve, C8 to T1, and the lateral part is the anterior interosseous branch of the median nerve, C8 to T1. So one of the few times we have a single muscle innervated by different nerves. So ulnar and median nerve innervation. We get to the flexor pollicis longus. Let me highlight that. So we see here its origin is the anterior surface of the radius in the adjacent interosseous membrane of the forearm, with the insertion into the palmar aspect of the base of the distal phalanx of the thumb. And so we know we cover a lot of territory here. Let me come in, and I want to hide that that sheath so that you can really see the distance there. So flexor pollicis longus. We go finally to pronator quadratus. Here, our origin is the anterior aspect of the distal 1/4 of the ulna, and it inserts into the anterior aspect of the distal 1/4 of the radius, and its action is pronating the forearm at the radial ulnar joint. Innervation here is anterior antebrachial interosseous nerve, C7, C8. Okay, so that's the elbow medial flexor group, our 3D anatomy. Let's look at some surface anatomy. So again, we've got a lot of written information on how to draw all of this information. Here we're looking at the medial epicondyle, medial supracondylar ridge, the common flexor tendon. These slides are available. I encourage you to get familiar with these. Whenever we get into our lab, we will want to draw these as far as our surface anatomy. But let's move on to our video representation here. So when dry needling the common wrist flexor and extensor, we want to look at some specific surface anatomy. First thing we want to do is identify our cubital crease. Very simply, we're going to come across that location right there. Then what we want to do is find our cubital triangle here. We talked about the danger zones. We want to stay out of this area as much as possible. And so first what we'll do, this triangle is bordered by brachioradialis and then Pronator Teres. So first off, we'll identify brachioradialis. You're going to have your subject hold and resist flexion. As you do that, you can identify the medialmost border of brachioradialis. So as we're doing that, go ahead and relax. Okay, come up again. Very good, and relax. That'll help me identify this border. And then what we want to do is come in to identify the medial most border. Is we're going to just place our finger in that cubital window and we're going to resist pronation. So if you will, roll your hand down. And that will give us that border there. So from there, I'll mark there. So this is our danger zone. We want to stay away from here. When we do get to dry needling, the extensor group will be lateral to this spot, and on the medial group will be medial. All right. Now let's look into our treatment of this forearm, both flexor and extensor group. Again, for our introductory piece and clinically, I will always treat these as a group, whether I'm dealing with the medial or the lateral aspect. We'll try that first. Normally we get good response and don't have to go deeper, but in the event that we do, then we'll cover those topics in our advanced treatment modules for the forearm. But for the flexor group, let me, and again, these slides are available. I'm going to move onto our video. So here you see a slide that I've put together. This is a representation of what's available on the app, the dry needling app that's available. If you have trouble finding that, send me a message and I can direct you to that. But this slide is just readily accessible, drilled down through to find your particular dry needling protocol. In it, you're going to get the group, the muscle, the tendon, ligament, whatever we're needling. We'll have our position, our needle length, our backdrop, any precautions, and then finally we'll have detailed instructions on how to effectively needle that area. So for the common flexor group, at the elbow for the common flexor group, the patient again is going to be in the supine position. Needle length here will be 30 to 40 millimeters, and there is no backdrop. Our precautions are the basilic vein, the ulnar nerve, the posterior ulnar recurrent artery and vein. So in the supinated position, we're going to palpate for the bicipital insertion into the radius. We're going to grasp the muscle belly of the flexor group medially, and then one thumb breadth distal to the biceps, insert the needle and advance in an anterior to posterior medial direction away from midline at a 45-degree angulation using the fingers to determine adequate needle depth.
Okay.
All right. So for our extensor, again, let's come through. Again, all this information is available, but let's get down to the 3D anatomy here of the extensor group, and then we'll get into the actual treatment. Okay, so let's move into the lateral elbow muscle group. We'll look at the superficial muscles, and then we'll move into the deep musculature. Again, we're going to look at the muscles that follow in a very predictable line of attachment. They can be palpated and followed from proximal down to distal on the lateral aspect. So first muscle will come in brachioradialis. We've talked about this one before, but for our purposes, we'll look at it again. So brachioradialis, the origin is the superior 2/3 of the lateral supracondylar ridge of the humerus. It inserts into the lateral aspect of the distal part of the radius. So we come way down. And so its action is it flexes the forearm at the elbow joint. Since that's the only joint that it passes, that's its action. It's innervation by the radial nerve, C5, C6. Next muscle in line is going to be the extensor carpi radialis longus. Here, our origin. Let me rotate a little bit. Again, the inferior 1/3 of the lateral supracondylar ridge of the humerus. Our surface anatomy, our palpation, need to be able to identify that so that we can then differentiate these muscles, both brachioradialis and ECRL. It inserts in the dorsal aspect of the base of the second metacarpal bone. So we get closer in. So here we have brachioradialis. It's its insertion, and then come further. We see ECRL, the longest, attaches to the base of the second metacarpal bone. When we get to ECRL brevis, we'll see that it attaches to right here into the third, right there. Okay, but back here. So here, our action extending the hand at the radiocarpal joint and abducting the hand at the radiocarpal and midcarpal joints. So that motion lets us identify with a little radial deviation, a little extension, resist those, let us identify those, that musculature itself. Okay, so innervation is the radial nerve, C6, C7. Again, we'll move up and look at extensor carpi radialis brevis. Here its origin is the lateral epicondyle of the humerus. So we're off of the lateral epicondylar ridge. Now we're actually on to the lateral epicondyle, and here's the start of the muscles that will form the common extensor tendon. Later, dealing with specific protocols, we'll talk about dry needling into that common extensor tendon. Again, the insertion is the dorsal aspect of the base of the third metacarpal. Its action, again, extending the hand at the radiocarpal joints or the wrist and abducting the hand at the radiocarpal and midcarpal joints. Innervation here is the deep branch of the radial nerve, C7, C8, and the posterior interbrachial interosseous nerve. Move further laterally. Now we're at the extensor digitorum. Again, its origin is the lateral epicondyle of the humerus via the common extensor tendon. It inserts into the dorsal aspects of the bases of both the middle and distal phalanges of the index, middle, ring, and little fingers. Its action is extending the second through the fifth digits, and it's innervated by the posterior antebrachial interosseous nerve C7 and C8. We finally move to our more lateral location, extensor carpi ulnaris. Again, origin is the lateral epicondyle of the humerus via the common extensor tendon and also the posterior border of the ulna. Can't really see that in this representation. It inserts the medial aspect of the base of the fifth metacarpal bone, and its action is extending and adducting the hand at the wrist joint. It's innervated by the posterior antebrachial interosseous nerve C7 and C8. So let's move back to the library. Let's look at the deeper musculature here. There's our superficial, extensor deep. Okay. So here, let's close that screen. All right. Okay, now let's come down to our surface anatomy. So, surface anatomy of the lateral elbow. Definitely first thing we want to take a look at is our lateral epicondyle, which I will draw right here. And coming up more proximally, we'll be able to identify our supracondylar ridge. And so this is important because it outlines our border between triceps here. Then we come anterior and we have our biceps and our brachialis. So we can identify a border between the biceps and brachialis prior to coming onto our supracondylar ridge. So brachialis is going to be fairly ropey, and it will not push away, but as we push in, we can move the biceps further medially. And so that will be our our delineation between brachialis and biceps brachii. As we come further distally, we can feel the distance between the lateral epicondyle and then the radial head. So we sense this joint space here, and then we can identify the superior border and the inferior border of the radial head. It will come down, merge more, and start to come together into more of the slimmer part of the radius. But a little bit later, we'll want to be able to get in between those joint surfaces. So for lateral surface anatomy, this is basically what we're looking at. Our joint space between the lateral epicondyle and the radial head. Follow the supracondylar ridge as it approaches the deltoid tubercle, and then that lets us identify triceps brachialis and biceps brachii. Okay, now for our extensor, our lateral treatment piece. Again, we're going to isolate. We're going to find our V-notch here using brachioradialis and Pronator Teres as our mark. We're going to move about thumb breadth lateral from that for our needling. Again, and here is our needling sheet that you'll find in the app. At the elbow, for the common extensor group, we're going to needle all of the muscles as one unit. Here, your needle length will be 30 to 40 millimeters. There's no backdrop. Precautions here also: radial nerve, the radial collateral artery, the radial recurrent vein, cephalic vein, and the muscular branch of the radial nerve to the brachioradialis, and the accessory cephalic vein. So in a supinated position, we're going to palpate for the bicipital insertion into the radius. We're going to grasp the muscle belly of the extensor group, and then 1 finger breadth distal to the biceps insertion, we'll put the needle and advance in an anterior to posterolateral direction away from midline at a 45-degree angulation, using the fingers to determine adequate needle depth. Okay, now let's move on to the upper leg. Here we will deal on the posterior thigh first: semitendinosus, membranosus, biceps femoris, and adductor magnus. These will be the introductory needling approaches when we move into the advanced modules for the hip and lower leg. We will break these down into more detail, but this is a nice place to get started needling into and have an effect on these muscles. We will take a look momentarily at our three-dimensional anatomy. Again, these slides are all available to you in the student portal for more detail, but let's move straight into our 3D anatomy. So let's look at the muscles of the posterior thigh. Here we're talking about semitendinosus, semimembranosus, biceps femoris, and the adductor magnus. First, the semitendinosus. Pull that up, get that highlighted. Okay, so its origin is off of the ischial tuberosity. Let me get in nice and close so that you can see the attachment. And basically, all the hamstrings here with this ischial tuberosity attachment, as well as part of adductor magnus on the most inferior aspect of that piece. But so semitendinosus there. We're going to come down. You'll see it will course and go all the way down for its distal attachment under the medial aspect of the proximal part of the tibia, it being one of the muscles or the tendinous part of the pes anserine. semitendinosus, its action is flexing and medially rotating the leg at the knee joint and extending the thigh at the hip joint. It's innervated tibial division of the sciatic nerve, L5, S1, S2. We'll move further to the semimembranosus. So its origin, again, ischial tuberosity. It actually will insert more laterally and anteriorly than does semitendinosus. Its insertion is the medial condyle of the tibia, so it's going to have a further posterior trajectory at the joint line than does semitendinosus. Its action is flexing and medially rotating the leg at the knee joint, and it extends the thigh at the hip joint. It's innervated L5, S1, S2. We'll look at the biceps femoris. I'm sorry, the long head, we'll look at that first. The long head of the biceps femoris, in origin, ischial tuberosity, so its origin is actually between the origin of semitendinosus and semimembranosus. We'll get to dry needling protocol where we will actually needle through all three of these tendons to elicit a change in those structures. Again, long head of biceps, its insertion is into the head of the fibula. So I'll highlight that and we can see its distal attachment, again, onto the head of the fibula. It's, come back up. Its action is it flexes and laterally rotates the leg at the knee joint and extends the thigh at the hip joint. And innervation, again, tibial division of the sciatic nerve, L5, S1, S2. Lastly, we'll look at Adductor Magnus. So actually before that, we also want to look at the short head of the biceps femoris. And so the origin is the linea aspera and the lateral supracondylar line. And then its insertion is into the the head of the fibula as well, via the tendon. So it has an actual attachment onto the biceps femoris tendon as it travels then via that tendon down to the head of the fibula. Its innervation or its action is going to be flexing and laterally rotating the leg at the knee joint, and its innervation is the common fibular division of the sciatic nerve, L5, S1, S2. Now we move on to the Adductor Magnus, and I'm going to look at it first in relation to the biceps femoris, the hamstring group. So let me zoom in here. So the Adductor Magnus, as the name implies, it covers a lot of territory. It's a large muscle. As we look at its origin, you can see it on the anterior part of the pelvis, following the inferior ramus all the way around. Move that. There we go. To the most inferior aspect of ischial tuberosity. And so a broad attachment, and then its insertion. So again, the origin, the inferior pubic ramus and the ramus of the ischium and the ischial tuberosity. So its insertion is in the gluteal tuberosity, the linea aspera, the medial supracondylar line, and finally the adductor tubercle. We tend to end up needling Adductor Magnus in the bulk of the muscle belly, and depending on the protocol, we may also needle directly onto the adductor tubercle. Get all the way over there on the medial aspect of the knee. Okay, so that is our 3D anatomy. Let's look at, come down at some surface anatomy. In looking at surface anatomy for the posterior upper leg, one area a little bit later we'll be interested in is in being able to palpate and identify ischial tuberosity. I'm not going to mark that at this point. Another thing that's incredibly important with a lot of our landmarks, especially dealing with posterior hip structures, is being able to identify the superiormost aspect of the greater trochanter. Again, at this point for this session of needling, we don't need that for our lower. But where we do need to get is in our, similar to in the elbow, we need to identify our window in the posterior lower leg. So one thing we want to do, first off, we want to identify the popliteal crease. Okay, then we want to identify a lateral and a medial margin. And quite honestly, very simply, we just want to bring the hamstrings, resist knee flexion to identify semitendinosus, semimembranosus. Go ahead, come again. There. And at the same time, we can identify our lateral border. Go ahead and resist. Very good there. So again, our danger zone, we want to avoid structures in the midline right here. When we're talking about dry needling into biceps femoris and into semitendinosus, membranosus, this is our identifier. We can come lateral to those lines, medial to those lines, and that gives us what we're looking for. Since we're here, we'll need it a little bit later. We're definitely going to want to know the location of the fibular head. This isn't always the best position to do this, but we're here. And so let's go ahead and mark the superiormost aspect there. Fibular head, and then dropping off into the fibular neck. There. So let's look at our posterior thigh treatment. Basically here we're going to look at, again, introductory piece here, effective beginning treatment approach. We'll get to more advanced in the advanced modules. But let's look here. We'll start with the Adductor Magnus. Again, I'm going to skip down to our live demonstration here. As you can see, for this piece, we're going to just be in the supine position. We're going to lay our subject's leg across ours and grasp that muscle and then needle through it using our fingers as a backdrop. For the Adductor Magnus, patient position will be supine, needle length is 30 to 40 millimeters, and there is no backdrop. Precautions here for the great saphenous vein and the obturator nerve. With the patient in supine, the hip externally rotated and the knee at 90 degrees flexion, have them adduct into your hand and palpate for the prominent adductor longus. Ideally, have them rest their leg on your knee placed on the table. We'll grasp the bulk of the muscle posterior to the longus with the lumbrical grip at mid-thigh and needle perpendicular to the table into the bulk of the muscle. Okay, so for the biceps femoris, the long and the short head, again, in our surface anatomy, we drew our posterior triangle. We're staying about a palm breadth cranial from the popliteal crease. That way we avoid this neurovascular bundle. Once we get palm breadth up, we're going to go one thumb breadth away from midline, or lateral in this case. When we do the semitendinosus and membranosus, we'll see that we do one thumb breadth medial to that same location. So let's move into our video of that. For the biceps femoris, long and short head, patient again is going to be in the prone position. Needle length here is 30 to 40 millimeters, and the backdrop is going to be either the femur or none at all. Precautions for the common fibular nerve and the posterior femoral cutaneous nerve. In prone position will be one palm width superior to the popliteal fossa. We'll grasp the outer muscle bundle with a lumbrical grip and needle from one thumb breadth lateral to midline and a medial to lateral angulation away from the femur. Using your fingers, determine adequate depth. Caution here to avoid the popliteal neurovascular bundle, which is deep, and the posterior femoral cutaneous nerve, which is superficial. So in that particular case, you'll see that with the length of that needle, I will also have needled into a little bit of the vastus lateralis. Nothing wrong with that. Never hurts to have some more muscle interaction with the longer needle if you can. Again, using my left hand here, my fingers on the opposite side to determine that I don't go too deep. And then for semitendinosus and semimembranosus, again, same landmarks, same distances. In this case, we're just going to go medial away from midline as opposed to lateral. For the semitendinosus and semimembranosus, the patient will be in the prone position with a 30 to 40 millimeter needle. The backdrop here will be the femur or none. Precautions: the great saphenous vein, the posterior femoral cutaneous nerve. In prone will be one palm width superior to the popliteal fossa. We'll grasp the inner muscle bundle with a lumbrical grip and needle from one thumb breadth lateral to midline and a medial to lateral angulation away from the femur. Using your fingers, determine adequate depth. Caution here to avoid the popliteal neurovascular bundle, which is deep, and the posterior femoral cutaneous nerve, which is superficial. Okay, so we'll move on to the anterolateral thigh. Here we'll look at our sartorius and then rec fem, vastus lateralis, intermedius, and medialis. Very, very frequently being heavy into lower extremity. These are some of the big things, big muscles that we find that we needle on a fairly consistent basis. So we'll look at, come down, let's move into our three-dimensional anatomy. And again, if you haven't invested in some sort of a required access to a three-dimensional anatomy program, I strongly encourage it. It can be a game changer for your understanding of anatomy as you're trying to insert needles into here. It's one thing to look at the measurements and the finger breadths, thumb breadths, palm breadths, and orientation. It's another thing to understand it on the different patients and subjects that you will treat. Okay, 3D anatomy of the anterolateral thigh. Here we'll look at the sartorius and then the quads themselves. So let's start with sartorius. Sartorius, longest muscle in the body. Its origin is the anterior superior iliac spine. It curves from a lateral to a medial direction to then insert on the medial aspect, proximal part of the tibia being one of the three pieces of the pes anserine. Its action is it flexes and medially rotates the leg at the knee joint. It assists in flexion, abduction, and lateral rotation of the thigh at the hip joint. It's innervated by the femoral nerve L2 and L3. Okay, so I'm going to go ahead and hide sartorius so we can have a really good look at the muscles of the quadriceps. First, let's look actually deep at the vastus intermedius. Its origin in the anterior and lateral surfaces of the body of the femur. Rotate there. So distal to the greater trochanter, about the line of the lesser. Its insertion is into the tibial tuberosity via the tendon of the quadriceps femoris muscle. It's not demonstrated here, but it's through the patellar, the quad tendon into the patella, and then ultimately tibial tubercle through the patellar tendon or the patellar ligament. Its action is extending the leg at the knee joint, and again, innervated by femoral nerve L2 through L4. So look next at Rectus Femoris, or Rect Fem. Its origin will come up nice and high, will be on the anterior inferior iliac spine in the supraacetabular groove of the ilium. It inserts in the tibial tuberosity via the tendon of the quadriceps femoris muscle and the patellar ligament, and its action is extends the leg at the knee joint, and it flexes the thigh at the hip joint. So crossing two joints has dual functions. Innervation femoral nerve L2, L3, L4. I will hide that. And Vastus Intermedius as well. Okay, that gives us down to Vastus Medialis and Vastus Lateralis. Let's look at Vastus Medialis first. The Vastus Medialis origin the medial part of the intertrochanteric line and medial to the spiral line in the linea aspera of the femur, extending inferiorly to the medial supracondylar line. So its origin is a fairly broad footprint, and then inserts again into the tibial tuberosity via tendon of the quadriceps femoris and the patellar ligament, and it's there at the medial border of the patella. So let's hide that, and then let's look at its innervation L2, 3, 4 femoral nerve, Vastus lateralis. So here, that hand is in the way. Okay, so its origin, the intertrochanteric line, the greater trochanter, the gluteal tuberosity, and the lateral lip of the linea aspera of the femur. So again, fairly large footprint for its origin, and it inserts again at the lateral aspect of the patella via the quadriceps tendon, and tibial tuberosity via the patellar ligament. Again, its innervation femoral nerve L2, L3, L4. One thing of note, it's not listed here, but let's try to put in the iliotibial tract. On the right. Okay, let's come back to it. So whenever palpating the IT band, you can see it actually comes down and envelops the majority of that vastus lateralis. However, the most prominent part that we can palpate will fall right in line right here. So a decent amount of vastus lateralis sits posterior to the IT band that we can palpate. Okay, so let's look at surface anatomy. Again, a lot of information. These slides are available, but a lot of this we'll cover in a lot more detail when we get into the advanced modules. So our surface anatomy for our anterolateral thigh, probably the most important thing is we want to be able to first identify that iliac crest, and so we can just palpate and come up and around. So our next thing is we're going to want to know is greater troch. So I'm going to drop into, and I'm going to butt up against the cranial-most aspect of that greater trochanter. So a couple of things we become aware of is our TFL and our IT band are going to be palpable running all the way up to the iliac crest. If you're uncertain, you can have your patient abduct a little bit, and it'll just pop right out there. But for TFL, whether we're threading across or if we're doing it direct, or we also know that this midpoint is where our location for gluteus minimus is. And so later we'll look at surface anatomy again, but for the advanced part of the hip, identifying this will let us also deal with our trochanteric bursitis and dealing with our piriformis. Our piriformis has an attachment just medial to this ridge as it comes across through here, going posteriorly to its sacral attachment. And so that becomes very important as well. But as far as our surface anatomy of the posterolateral hip, iliac crest, superior aspect of the greater trochanter, then being able to identify that IT band as it's approximating more proximally onto the iliac crest. All right, and then let's look at our treatment, quads and sartorius. So for sartorius, we can follow that muscle from its origin all the way to its insertion. If we're targeting specifically, one of the easiest ways to make sure that we're isolating it is just off of the ASIS. So we're just going to locate that ASIS, and we're going to drop 2 to 3 finger breadths caudally, and we can needle there. About 30 millimeter needle is all we're going to need to isolate that. For the sartorius, position is going to be supine. Needle length is going to be 30 millimeters, and there's no backdrop. Precautions here for the ilioinguinal nerve, the anterior cutaneous branch of the iliohypogastric nerve, the lateral femoral cutaneous nerve, the superficial circumflex iliac artery and vein. And supine, we're going to locate the ASIS, and with the knee at 90 degrees and hip externally rotated, we're going to have the patient lift the heel toward the buttocks. To needle the muscle, follow it 2 to 3 finger breadths caudally. Caution for the neurovascular bundle and the femoral triangle. Sartorius is the lateral border. And insert the needle into the muscle with a medial to lateral orientation. The muscle can be isolated with a pincer grip or by bracketing. Then for rec fem, again, we're going to take a more proximal location to identify the target rec fem in this particular case. This is a nice beginning location so that you can isolate it from vastus lateralis or medialis or intermedius. Clinically, we probably would go more mid-belly to treat this. However, in this particular case, I want you to have the ability to isolate that so that you can treat it more diagnostic approach by just needling that muscle without needling the others as well. For rectus femoris, the position is supine. Needle length here is going to be 30 to 40 millimeters. The backdrop is either going to be the femur or none at all. Precautions here are for the lateral circumflex femoral artery and vein, the lateral femoral cutaneous nerve, the superficial circumflex iliac artery and vein, and the muscular branches of the femoral nerve. To needle the rectus femoris, we'll palpate the ASIS and the apex of the greater trochanter. We'll insert the needle where the lines of those points intersect between the sartorius and the TFL and advance in an anterior to posterior angulation. There will be no backdrop unless needling deeper to the vastus intermedius. Okay, for vastus lateralis. For the vastus lateralis, the patient will be in the supine position and needle length will be 30 to 40 millimeters. The backdrop here will be the femur or none. The precautions are for the lateral femoral cutaneous nerve, the descending branch of the lateral circumflex femoral artery. This can be treated in a direct or a threading approach. Both methods utilize the IT band as a reference. In the direct approach at mid-thigh, locate the anterior border of the IT band by resisting abduction. We'll needle from lateral to medial with a 10 to 20 degree posterior angulation with the femur as a backdrop. In the threading approach, we'll locate the IT band at mid-thigh. We'll grasp the muscle belly of the lateralis and advance the needle in an anterior to posterior direction towards the table about 1 finger breadth medial to the medial border of the IT band, using your fingers in the posterior side to assist in determining the appropriate depth. That was the direct approach, and here is the threading approach. Okay, and we'll move into the Vastus Intermedius. So this will be mid-thigh. Clinically, this is probably the most common approach to treat rec fem. However, again, we discussed earlier, we wanted to treat rec fem as well up high so we can isolate it from the other 3 muscles of the quad. But clinically, this is probably the more common approach to treat rec fem. But this is for Vastus Intermedius. For Vastus Intermedius, patient is in the supine position and we're using a 30 to 40 millimeter needle. The backdrop here will be the femur. Precautions here also: the lateral circumflex femoral artery and vein, the lateral femoral cutaneous nerve, the superficial circumflex iliac artery and vein, and the muscular branches of the femoral nerve. Needle this muscle mid-thigh, passing through the rectus femoris. Orientation is aligned from the ASIS to the patella. We'll advance the needle in an anterior to posterior angulation using the femur as a backdrop. Okay, and then finally we'll hit our Vastus Medialis. For the Vastus Medialis, the patient is in the supine position. Needle length here will be 30 to 40 millimeters. The backdrop is going to be the femur. Precautions: femoral artery and vein, the saphenous nerve, the muscular branch of the femoral nerve. The needling location is 3 finger breadths superior to the medial superior pole of the patella, and then 2 finger breadths medial. We'll insert the needle in an angle towards the femur using it as a backdrop. All right, there. All right. So that is the anterior and posterior 3D anatomy, surface anatomy of the upper leg. Now let's move into the lower leg. We'll look at anterolateral first. Here we'll look at our tib anterior, extensor digitorum longus, extensor hallucis longus, and then our peroneals will go in this order: tertius, longus, and brevis. And so let's move into, going to skip through this. Again, this is all available for your review, but let's move into our 3D anatomy next. And then 3D anatomy of the anterolateral lower leg. Here we'll look at tib anterior, the extensor digitorum longus, the extensor hallucis longus, sitting right there, and then the peroneal or the fibularis longus, brevis, and tertius muscles. So first let's talk about tib anterior. Let's fade the others. So, oops. Try that again. Fade the others. Good. Not sure what's happening there. Try it one more time. Fade the others. All right. Okay, so tibialis anterior It has as its origin the lateral condyle of the tibia, the proximal half, the lateral surface of the tibia, and the adjacent interosseous membrane of the leg. It inserts into the infromedial aspect of the medial cuneiform and get further down right there, and the base of the first metatarsal. Its action, it dorsiflexes the foot at the ankle joint, and it inverts the foot at the subtalar and the transverse tarsal joints. It's innervated by the deep fibular nerve, L4, L5. Okay, we'll come up, and actually I'm going to hide that from view so that we can now look at extensor digitorum longus. So extensor digitorum longus, the origin is the lateral condyle of the tibia and the proximal 3/4 of the fibula and the adjacent interosseous membrane of the leg. It inserts in the dorsal aspects of the bases of both the middle and distal phalanges of the second, third, fourth, and fifth little toes. Let's see that out further distally. So interestingly, we'll get to this when we dry needle. We're going to use the fibula as our backdrop here. So we'll catch tibia anterior right about here. Extensor digitorum longus will catch right about this area, just dropping down into that muscle right anterior to the fibula. Okay, and then let me go ahead and hide that. Okay, and now the extensor hallucis longus. So here, origin will be the medial surface of the fibula. So whereas extensor digitorum was just anterior, this is going to sit a little bit medial, and it's in the adjacent interosseous membrane of the leg. It inserts in the dorsal aspect of the base of the distal phalanx of the big toe. It extends the great toe and it dorsiflexes the foot at the ankle joint to a lesser degree. Its innervation is the deep fibular nerve with the root of L5. Okay, and I'm going to leave that one in place. Let's move up to Peroneus longus or Fibularis longus. Its origin is going to be the head of the fibula, of the lateral surface of the fibula and the adjacent intermuscular septa. It inserts into the plantar surface of the medial cuneiform at the base of the first metatarsal. So as we see that coming down and around, there is its insertion. So very circuitous route for Peroneus longus. All right, and it's also innervated by the superficial fibular nerve L5S1. Okay, I'll hide that so that we can see Peroneus brevis. Okay, so Peroneus brevis, its origin is the lateral surface of the fibula and the adjacent intermuscular septa. It inserts in the tuberosity of the fifth metatarsal bone. And so whereas Peroneus longus follows a very similar course posterior to the lateral malleolus, their final insertion is on opposite sides of the foot. So they play a big role in an inversion, eversion there. The action, it everts the foot at the subtalar and transverse tarsal joints, and it assists in plantar flexion of the foot at the ankle joint. It's also innervated by the superficial fibular nerve L5S1. So finally we'll hide that, and then we'll get to Peroneus tertius. Here our origin is a medial surface of the fibula. The adjacent interosseous membrane of the leg, it inserts into the dorsal aspect of the base and body of the fifth metatarsal bone. So Peroneus longus took a posterior route to insert here, and tertius inserts more dorsally. Its action, it dorsiflexes the foot at the ankle joint. It assists in eversion of the foot at the subtalar and the transverse tarsal joints, and its innervation is the deep fibular nerve L5S1. Okay, so that's our 3D anatomy. And surface anatomy. Let's see what we've got here for our surface anatomy. Anterolateral. Let me scroll a little bit. Okay. For surface anatomy of the lower leg, especially the anterior lateral, anterolateral aspect, we want to first identify the patellar border, or the apex, inferior pole. From here, we can have our patient extend the knee briefly to help identify the medial and lateral, go ahead and relax, borders of the patellar ligament. Again, I marked it on the other leg, but we next want to look at the fibular head. We use the fibular head in a lot of our, as an important landmark for a lot of our needling structures. Also important to identify the tibial crest, because it's going to be used on our needling here as well. Since we're here, we also want to be able to identify our joint line, because that will be useful for identifying our lateral collateral ligament. Use it medially as we come along to identify our medial collateral. I'm not going to draw it, but we also want to be able to identify our lateral malleolus and our medial malleolus. So a lot more surface anatomy that we'll get to whenever we get to the advanced portion of the knee and lower limb. For what we're going to do in this session, these structures give us everything that we need. Okay, so let's go to our intralateral lower leg treatment. We'll start with tibia anterior, and I'm going to move straight on to our videos demonstrating actual treatment here. Again, these slides are available, and on the app you have them all laid out with the information that you need. Again, position, needle length, backdrop, any precautions, and then point by point location where needle placement, angulation, and depth need to take place. For the tibialis anterior, the patient will be in the supine position. Needle length here will be about 30 millimeters with the backdrop onto the tibia. Precautions for the anterior lateral genicular artery, the anterior tibial recurrent artery, the circumflex fibular artery and vein, the anterior tibial artery, the anterior tibial veins, and the deep fibular nerve. The needling point will be 2 to 3 finger breadths distal to the tibial tuberosity and 1 to 2 finger breadths lateral from the tibial crest. We'll needle from anterolateral to posteromedial with the lateral tibial surface being the bony backdrop. Caution regarding the deep fibular nerve, anterior tibial artery and veins at the interosseous membrane. If the needle goes posterior to the tibia, there is a risk of contact with those structures. Okay, so extensor digitorum longus. This in black, that was where we needled for anterior tib. Now we're going to come a little bit further laterally. We're going to drop 3 finger breadths down, and we'll needle onto the fibula to identify a needle for our treatment for extensor digitorum longus. For the extensor digitorum longus, patient again is in the supine position. Needle length will be about 30 millimeters. There will be no backdrop. Precautions for the anterior lateral genicular artery, the anterior tibial recurrent artery, the circumflex fibular artery and vein, the anterior tibial artery and the anterior tibial veins, and the deep fibular nerve, the lateral sural cutaneous nerve. Here we're going to palpate the anterior surface of the fibular head. We're going to move 3 finger breadths distal and insert the needle in its anterior posterior angulation. The muscle is superficial, 15 to 20 millimeters of depth, and we might contact the fibula as a backdrop. Again, as we'll cover here in just a moment, we may get some fibers from Peroneus longus here, or anterior tib as well. Certainly nothing wrong with that, but our target here is to isolate the extensor digitorum longus. Okay, so we're going to move further distally for the extensor hallucis longus. The extensor hallucis longus position, supine, preferably on a bolster. Needle length is about 30 millimeters and the backdrop is down to the tibia. Precautions here: the anterior tibial artery and veins, the deep fibular nerve. Extensor hallucis longus can be best palpated as the patient extends the great toe. Needling location will be 4 to 5 finger breadths superior from the apex of the lateral malleolus, and then 1 finger breadth lateral from the tibial crest, and a lateral to posteromedial trajectory with the tibia as a backdrop. Caution of the anterior tibial artery. We'll move to the peroneals. We'll start with Pronator Teres. And the reason for that is we're going to use a similar landmark for what we just did with our previous needle stick. For Pronator Teres, position again supine on a bolster. Needle length is 30 millimeters with no backdrop. Precautions here: superficial fibular nerve and the perforating branch of the fibular artery. Needle location is located 4 finger breadths superior to the lateral malleolus, anterior to the lateral fibular border. Needle angulation is lateral to medial with no backdrop. Okay, we'll move into Peroneus longus. Again, very common muscle to be treated, Peroneus longus and anterior tib, but here we are. For the Peroneus longus, the patient will be in the supine position. Needle length will be about 30 millimeters. The backdrop here is going to be the fibula. Precautions for the anterior lateral genicular artery, the anterior tibial recurrent artery, the circumflex fibular artery and vein, the anterior tibial artery, the anterior tibial veins, the deep and common fibular nerve, and the lateral serrocutaneous nerve. The muscle sits in the proximal 2/3 of the fibula. So 4 finger breadths distal from the fibular head will bracket the muscle belly and the lateral to medial using the fibula as a backdrop. Okay, then let's move to Peroneus Brevis. For Peroneus Brevis, again, supine, knee on a bolster. Needle length is about 30 millimeters. Our backdrop here is the fibula. Precautions: the lateral serrocutaneous nerve. This muscle sits on the lower third of the distal fibula, where the needle angulation is perpendicular to the fibula, 3 finger breadths superior from the Peroneus tertius needle point, which is 4 finger breadths superior from the apex of the medial malleolus. And we're going to go from lateral to medial with the fibula as a backdrop. So we go another 3 finger breaths, more cranial. Go anterior to the fibula to get Pronator Teres. Okay, now let's go to our posterior compartment. Here we'll look first superficial and then we'll go deep. Superficial, we'll look at our gastroc, soleus, and plantaris. So let's start by just jumping into our 3D anatomy here. For our superficial posterior lower leg muscles, we'll look at the plantaris, the gastrocnemius, and the soleus. So let's actually start with gastrocnemius. Both a lateral and a medial head. The lateral head, the origin is the lateral condyle and lateral supracondylar line of the femur. So crosses that joint line for its origin, and then inserts into the posterior surface of the calcaneus via the calcaneal tendon. Its action is plantar flexion of the foot of the ankle joint, and because it crosses the knee joint, it also flexes the leg at the knee joint. It's innervated by the tibial nerve S1 and S2. On the medial head, again here, its origin, get that back, is the medial condyle and the popliteal surface of the femur. So you'll see it is not far from the adductor tubercle where Adductor Magnus inserts. Its insertion, again, posterior surface of the calcaneus via the calcaneal tendon, and also plantar flexion of the foot and flexion of the leg at the knee joint. Innervation, again, tibial nerve S1, S2. So I'm going to hide gastrocnemius. Okay, then we'll look at, let's look at plantaris. Plantaris, its origin is the lateral supracondylar line of the femur, so it's going to sit just medial to the lateral head of the gastroc. It inserts in the posterior surface of the calcaneus, so long tendon that runs just anterior. Let's see if we can still see that there. So the calcaneal tendon. Between that and then the surface, or posterior to the surface of soleus. Its action assists in plantar flexion. It's a weak plantar flexor of the foot at the ankle joint and assists in flexion of the leg at the knee joint. Innervation here, tibial nerve S1, S2. How relevant is plantaris? It's hard to say. I always like to think that the plantaris is the cause of a lot of posterior knee pain. Odds are it's probably not involved that much, given how small it is, but it is there and it can be needled, and we will cover that in our introductory dry needling session. So we'll hide that and get down to soleus. Soleus, the origin is going to be the head of the fibula, and then the posterior surface of the fibula and the soleal line and medial border of the tibia. So two different bone origins for soleus. Big, broad muscle responsible for more power for plantar flexion. It inserts the posterior surface of the calcaneus via, again, the calcaneal tendon. And actually, let me move that. Okay, so its fibers insert much further distally into that tendon. And it's actually, again, plantar flexion of the foot at the ankle joint, and again, tibial nerve innervation S1, S2. Okay, so that's our 3D anatomy. Some surface anatomy. Let's take a quick look here and see that. For the muscles of the lower leg, one thing we want to differentiate is where the Achilles tendon itself starts to come a little bit more broad laterally, and then where we actually see the muscle bulk of gastrocnemius. So I'll apologize here. My camera angle was not the best. All the action is occurring over here on the right-hand side of your screen. We identify that because we're going to want to also needle into the myotendinous junction in this area whenever we're dealing with needling of the Achilles. And so we can resist, give me some gas pedal. There we go. We can follow that Achilles all the way up, and then we can find that line of demarcation where gastroc starts to become a prominent muscle, and that will give us our location there. If we wanted to, we could identify the distalmost aspect of the Achilles, but really this is the line that we're interested in here. As we needle the gastroc up higher, we can simply use a line bisecting medial from lateral to make sure we catch both heads there. Okay, so our superficial posterior lower leg treatment. We'll start with the gastroc, and let's go to our video. Here's our slide that's on the app for your reference, but let's come to the video of gastroc. For the gastrocnemius, the patient will be in the prone position. Needle length here will be 30 to 40 millimeters, and there's no backdrop. Precautions for the popliteal artery and vein, the small saphenous vein, the tibial nerve, medial lateral cerulocutaneous nerve, the posterior femoral cutaneous nerve. This can be treated in either the prone or the supine position. In either position, 4 finger breadths distal from the popliteal crease will grasp the medial, which is more common than lateral, gastrocnemius, and then will needle with an angulation from posterior medial to anterolateral away from midline to avoid the midline neurovascular structures. All right, and to the soleus. So you'll notice with gastroc demonstrated on one side, the gastroc can and should be treated bilaterally to make sure we get both heads. Similarly in soleus, it can also be treated and probably should be treated bilateral on either side of that tendinous section of the muscle as it's heading down toward its insertion. For the soleus, patient again is in the prone position. Needle length will be 30 millimeters and there is no backdrop. Precautions here, the posterior tibial veins and arteries, the tibial nerve, medial and lateral cerulocutaneous nerve, and the saphenous nerve. This can be treated in prone or supine. In either position, at the midpoint between the popliteal crease and the malleoli, grasp the medial or the lateral aspect of the muscle belly and needle with an angulation from posteromedial to anterolateral away from the midline to avoid the midline neurovascular structures. Okay, then let's look at plantar teres. Again, I've had a handful of patients who actually had a true plantar teres dysfunction, needling that resolved their posterior knee pain. Not often that we'll find that to be the case, but I do want to give you this as a treatment option. We discussed the danger zone here of the popliteal fossa. Our finger breadths, our landmarks are very critical here because we're going to be close to this popliteal fossa, as you can see. We'll end up being a thumb breadth away from midline, and we'll go away from midline with our needles, so that ensures that we stay away from any dangerous location. For plantar teres, Position here is going to be prone. Needle length is 30 millimeters, and the backdrop is going to be down to the femur. Precautions: the femoral and popliteal artery, the popliteal and small saphenous vein, the tibial and the common fibular nerve. Plantaris sits medial to the lateral head of the gastrocnemius. Caution must be taken in the popliteal fossa of the neurovascular structures. Needle placement should be 1 thumb breadth lateral from midline in the popliteal crease at the level of the superior pole of the patella anteriorly, with a medial to lateral angulation. So landmarks, again, are extremely important. We're going to palpate on the anterior side for the superior pole of the patella. That is going to give our location on the posterior side for our needle placement. So we locate that. We carry that location all the way around. And from an inferior to superior location, that's going to tell us where that needle needs to be placed to make sure that we stay away from that neurovascular bundle. Again, 1 thumb breadth lateral, and we do have to get down to our bony backdrop in order to reach that muscle. It is deep. Okay, moving on to our deep posterior lower leg. These muscles frequently are involved as we get to our advanced module with our symptoms of plantar fasciitis, because they do originate in the deep posterior leg, but they all have insertion or cross through the plantar surface of the foot. So that's one of my our go-to first step before we stick needles into the foot, which we will, but we always start here when dealing with plantar fasciitis. So let's go on now to our 3D anatomy. We'll look at popliteus, flexor digitorum longus, flexor hallucis longus, and tib posterior. And for the muscles of the deep posterior lower leg, here we'll look at flexor digitorum longus, flexor hallucis longus, popliteus, and the tib posterior. So let's start with popliteus. Let me get a nice zoom in here. So its origin is on the groove for the popliteus muscle on the tibia. It starts at a medial location, and then moves superiorly and laterally to come and insert on the posterior surface of. So let me do that backwards. The origin is the groove for the popliteus muscle laterally, and then it takes an inferior and medial course to insert in the posterior surface of the tibia, superior to the soleal line. So always consider origin is the broader piece, but technically origin, insertion. Its action: it immediately rotates the leg at the knee joint. It unlocks the knee joint at the beginning of knee flexion. It's innervated by the tibial nerve L4, L5, and S1. Let's move to flexor digitorum longus. Let me pull it out. So another muscle with a circuitous route. The muscles of the deep posterior lower leg, as far as a treatment approach for why we're treating these, definitely some of this deep posterior calf pain, but as we'll see momentarily, these muscles all terminate on the plantar surface of the foot. So we use these extensively dealing with plantar fasciitis, any of the plantar surface of the foot. Always a good option. Treat these muscles first. See if we can reduce some muscle tension, some tightness in those tendons as they attach on the plantar surface. But flexor digitorum longus, the origin is the posterior surface of the tibia, inferior to the soleal line. It inserts into the plantar aspects of the bases of the distal phalanges of the second, third, fourth, and little toes. Its action is flexing that second through fifth toe and plantar flexing the foot at the ankle joint. Innervation here is tibial nerve L5, S1, S2. We move laterally For the flexor hallucis longus, here our, zoom in, our origin is going to be the distal 2/3 of the posterior surface of the fibula and the adjacent interosseous membrane of the leg. It inserts in the plantar aspect of the base of the distal phalanx of the great toe. So it's covered with a lot of connective tissue there. There's a tenosynovium and then just more tissue. Its action, it flexes the great toe and plantar flexes the foot at the ankle joint. Again, innervation is via the tibial nerve L5, S1, S2. And then finally, let me come in. I'm going to hide those two to give us tib posterior. Here the origin is the posterior surface of the tibia, inferior to the soleal line. It's posterior surface of the fibula and the adjacent interosseous membrane of the leg. So again, another of the muscles with multiple bony origin. Its insertion is, let me get all the way down here. Okay, so our insertion of tib posterior is the tuberosity of the navicular bone, the plantar aspects of the medial, intermediate, and lateral cuneiform bones, and the plantar aspects of the bases of the 2nd to the 4th metatarsal bones. Its action is inverting the foot at the subtalar and transverse tarsal joints, and it plantar flexes the foot at the ankle joint. Its innervation is the tibial nerve L4, L5. All right. So as far as our deep posterior leg treatment, let's just start with popliteus. Again, rare for this to be an issue, but I've probably seen the popliteus a little bit more frequent as a dysfunctional muscle with posterior knees than I have with plantaris, given it its function as a locking a muscle. But let's move into our video assessment here. For the popliteus, the patient position is going to be prone. Needle length will be 30 millimeters with the backdrop down to the tibia. Precautions: the popliteal and posterior tibial artery and veins, the right tibial nerve, and the great saphenous vein. The popliteus inserts on the posterior medial aspect of the proximal tibia above the soleus. It extends posteriorly to the lateral femoral condyle. Grafts the medial proximal gastroc and palpate the lateral tibial border. Needle location is at the opposite level of the fibular neck, 1 thumb breadth lateral to the midline of the heads of the gastrocnemius. Needle perpendicular, P to A, to the tibia to avoid medial migration to avoid the neurovascular bundle. Again, the fibular neck being our landmark for our location, then moving 1 thumb breadth away from midline. Okay, for flexor digitorum longus, flexor digitorum longus and flexor hallucis longus is going to be similar, just on opposite sides of the lower leg. For flexor digitorum longus, position here is going to be a prone position. Needle length is 30 millimeters, and the backdrop is the posterolateral aspect of the tibia. Precautions: the posterior tibial veins and artery. What we're going to do is compress the medial gastrocnemius at mid-calf and needle from posterior to anterior, from lateral to medial, with the lateral aspect of the tibia as a backdrop. We'll needle through the soleus before reaching FDL. Okay, and then very similar approach for flexor hallucis longus. For flexor hallucis longus, position again is prone with a 40 millimeter needle. Backdrop will be down to the fibula. Precautions, the fibular artery and veins, and the sural nerve. We're going to compress the lateral gastroc at the mid-calf and going to needle from posterior to anterior with the fibula as a backdrop. Again, similar, we're going to be needling through soleus as we advance this needle down to our target. And nothing wrong with that at all. Okay, and then tibialis posterior. For tibialis posterior, again, prone position, needle length about 30 to 40 millimeters, the backdrop down to the fibula. Precautions here, the fibular artery, the posterior tibial artery, posterior tibial veins, fibular veins, and the tibial nerve. To take a lateral approach, there will be 3 finger breadths distal from the fibular head. We're going to insert a needle and advance with a slight posterolateral to anteromedial angulation of about 10 degrees posterior to the fibula with no backdrop. From a posterior approach, we're going to compress the lateral gastroc belly 3 finger breadths distal to the fibular head. Needle angulation is posterior to anterior towards the fibula as a backdrop. And then we also have the direct approach. First being threading, and now the direct. Again, here we'll catch the gastroc as well as some of the soleus in this approach. And then finally, let's look at our tendons and our ligaments. First, let's look at some three-dimensional anatomy. As we get into our more advanced modules, we'll go in a significant more amount of depth, but this is a nice introductory piece for probably the most common tendons and ligaments that we deal with here in the lower extremity. And finally, a 3D look at 4 of the tendons and ligaments in the lower leg. First would be the patellar ligament, the patellar tendon, patellar ligament. Technically, it's a ligament since it connects bone to bone. However, it's frequently referred to patellar tendon. Anyway, I digress. It's attached to both the tibial tubercle and the inferior pole, or the apex, technically, of the patella. Moving further laterally, the fibular or lateral collateral ligament. It's a broad band located along the lateral aspect of the knee. It originates from the lateral epicondyle of the femur, and then it passes obliquely to join the tendon of the biceps femoris muscle distally to form a conjoint tendon. The conjoint tendon inserts into the head of the fibula. Unlike the tibial or the medial collateral ligament, fibular collateral ligament is not fused to the lateral meniscus or the articular capsule of the knee. Hence, it is more flexible than the tibial collateral ligament and less susceptible to injury. And so let's go medially and let's look at the medial collateral or tibial collateral ligament. It's one of 4 major ligaments of the knee joint. It's a broad band on the inner knee and it attaches superiorly to the medial epicondyle of the femur, and inferiorly it attaches first to the anterior band of semimembranosus muscle and then continues inferiorly to attach the medial surface of the tibia deep to the pes and serine. Unlike the fibular collateral ligament, the tibial or medial collateral ligament is fused to the medial meniscus and the articular capsule of the knee joints. Hence, it is less flexible than the fibular collateral ligament and it's more susceptible to injury. And then lastly, let's drop and let's look at the Achilles tendon or the tendocalcaneus. So here it is the long tendon that attaches the muscle bellies of the triceps surae muscles to the posterior surface of the calcaneus. proximal end of the tendon begins in the middle of the leg, where the fibers of the triceps surae begin to converge and form this single tendon. Proximal to its insertion site, the calcaneal tendon spirals, which results in the gastrocnemius fibers inserting laterally on the calcaneus and the soleus fibers inserting medially. All right, so that's some of the three-dimensional anatomy. Let's now look at treatment here. All right, first lateral collateral. The fibular or lateral collateral ligament position treatment is side lying with the treatment side up. Needle length is 1.5 to 3 centimeters. There's no backdrop. Precautions here: the inferior lateral genicular artery. For the procedure, we'll palpate and determine the lateral joint line and the lateral collateral ligament. Needle location will be at the midline of the lateral collateral ligament, lateral to medial without a backdrop. Again, just going to test for the lateral collateral ligament, and I'm just going to go lateral to medial to needle into that ligament. If you can see in this, where this is frozen, I've got my phone out over here. As we go into all the advanced modules, you'll learn that there are hundreds of different needling protocols for specific tendons, ligaments, muscles, nerves, and for that, the app comes in quite handy to be able to drill down to each of those without carrying thick text around. There would be about 3 inches worth of text. So use of that electronic app comes in quite handy. Okay, then we'll look at the MCL. The medial or tibial collateral ligament position is supine with the knee on the bolster. Needle length is 1.5 to 3 centimeters. The backdrop will be the joint capsule and medial meniscus. Precautions here: the saphenous nerve, the articular branches of the tibial nerve, the inferior medial genicular artery and vein, and the superior medial genicular vein. For the procedure, we'll palpate the medial epicondyle of the femur. We're going to slide distally across the medial joint line to locate the broad fibers of the medial collateral ligament. The needle location will be in the joint line, medial to lateral angulation, perpendicular to the skin surface, with a backdrop of the joint capsule and medial meniscus as a backdrop. Again, we'll identify, go in the joint line, find the location. We can put it under a valgus load and needle into that. A little bit deeper here because we will go a little bit deeper into the capsule and possibly even into the meniscus, since there is attachment there. All right, the patellar ligament. The patellar ligament position is going to be supine with a bolster underneath the knee. Needle length is 1.5 to 3 centimeters with no backdrop. Precautions: the patellar anastomosis, the anterior tibial recurrent artery, and the articular branch of the tibial nerve. The procedure will palpate for the midpoint between the inferior pole of the patella and the tibial tuberosity, the attachment sites of the patellar ligament. The needle location is at the midpoint and in an anterior to posterior angulation. All right, and then lastly, to the Achilles tendon. For the Achilles tendon position for the patient for treatment, it's going to be prone. Needle length is 1.5 to 3 centimeters. The backdrop is either the calcaneus or none. Precautions here: the calcaneal branches of the posterior tibial and the fibular artery, the medial surocutaneous nerve, the surocommunicating branch of the fibular nerve. For the procedure, we're going to palpate for the junction of the Achilles tendon and the gastrocnemius. Here, needle location will be at this junction in a posterior to anterior angulation with 2 needles, 1.5 centimeters, one finger breadth medial and one finger breadth lateral to midline. Distally, we'll palpate for the attachment of the Achilles tendon to the calcaneus. Needle location will be at this junction with the calcaneus as a backdrop using a 1.5 centimeter needle pecking on the periosteum and a posterior to anterior angulation. Again, so we'll catch it in two locations, one at the myotendinous junction on both sides, but then we'll catch it again. Apologize for the poor camera angle, but then we'll needle it there at the actual attachment itself onto the periosteum. And that is all of the introductory material. That is all of the module, the lecture component, and all of the pieces that we'll look at for our first 8 hours worth of lab. Again, 65% of everything that we see clinically is contained in this first introductory piece. The advanced components, modules 5 through 16, has an abundance of advanced material, and I encourage you to, if you haven't, to go ahead and register for that piece and start going down into that. If you're interested in signing up for the lab, follow us on our website, our social media area to register for that as well. The hands-on in-person lab is the only way to really get adept with this technique. Anyway, post-module assignment. Again, this is for kind of the entire introductory 4 modules. Your patient has shoulder impingement. Pain is 4 out of 10 with flexion and abduction. Strength is 4 out of 5, and there's tenderness in the posterior and lateral shoulder. I want you to name 6 muscles that may be involved in order of likely importance. So up next, for those that are attending the lab, is there are 53 specific needle sticks, if you will, during this lab session. 8 hours. It takes a lot to get through that, but for those of you who are going to attend, look forward to seeing you there, and if not, I hope to see you in the next advanced module, which I believe next one is going to be the advanced cervical spine. So either see you at the next lab or see you on module 5.